Welcome, everyone. APIC Consulting Services is pleased to present this online education program. Our session is titled Lower the Risks, Keeping Your Workforce and Work Environment Safe from COVID-19. The sponsors of today's program are the South Carolina Hospital Association, the South Carolina Chamber of Commerce, and Blue Cross Blue Shield of South Carolina. Please note we are recording and we muted all participant lines. If you need help at any time, please send us a message in the chat box or send an email to apic@compartners.com. If you have trouble with streaming audio, you may press the F5 key on your keyboard to refresh your screen. Today's presentation will last up to 60 minutes and does include a question and answer period at the end. To ask a question, simply type it into the chat box in the lower left corner of your screen and then be sure to click the send button. Please do post your questions at any time during the presentation, and we will just answer those once the presentation is over. This program is presented by APIC Consulting Services, a subsidiary of the Association for Professionals in Infection Control and Epidemiology. APIC Consulting is a consulting firm with board-certified infection prevention and control experts. Currently, APIC Consulting is working with businesses to minimize risks of COVID-19 transmission and keep employees and customers safe. For more information, please visit www.apicconsulting.com. APIC Consulting Services is now pleased to introduce our speaker. Dr. Terri Rebmann is the Associate Dean for Academic and Faculty Affairs, Director of the Institute for Biosecurity, and a Professor of Epidemiology in the St. Louis University College for Public Health and Social Justice. She is a PhD nurse researcher with an emphasis in infectious disease emergency preparedness. In addition, she is board certified in infection prevention and epidemiology and an Association for Professionals in Infection Control and Epidemiology APIC Fellow. She publishes and lectures on bioterrorism, pandemic planning, emerging infectious diseases, and infection prevention practices on a national basis. Dr. Rebmann has served on several national and international task forces and committees aimed at minimizing morbidity and mortality related to emerging infectious diseases and bioterrorism threats. Examples include being a member of the APIC COVID-19 Task Force, a member of the APIC Ebola Task Force, and being a former member and chair of the APIC Emergency Preparedness Committee. Dr. Rebmann, we're so pleased to have you today, and I'll turn it over to you to get started.
Thanks so much. Okay, so what we're going to talk about today, we're going to discuss the current epidemiology of the SARS coronavirus 2, which causes the disease, COVID-19. We're going to describe infection prevention strategies to prevent disease spread in non-healthcare businesses. And we're going to outline CDC and evidence-based recommendations and best practices for identifying and managing employees that have COVID-19. So I want to start with a quick disclaimer that the information that I pulled together was collected last weekend, and then I checked everything last night to make sure that it was still up to date. So everything is current as of last night. But it will be very helpful for you if you're developing your own business continuity plan or response plan for COVID-19 to make sure that you are checking the CDC website on a very frequent basis, including possibly even daily, because the recommendations are changing on a very rapid basis. It's also really important that you work with your occupational health nurse or physician if you have such an individual or such an office for your business. And then lastly, if you have a known or highly suspected staff exposure, you should work with your local public health officials about how to respond to that exact scenario. Please note the CDC has said that their responses to different staff exposures are considered to be adaptable, so they encourage you to work with local public health officials. And then lastly, this webinar is not intended for healthcare agencies. The recommendations are very different and more stringent for healthcare agencies and businesses, so please refer to other resources if you do work for a healthcare institution. So coronaviruses are respiratory viruses that were first identified in the 1960s. Most human coronaviruses circulate every year, and they cause a mild respiratory illness that's similar to a cold. However, we have had 3 novel coronaviruses that have emerged since 2002. There was the first SARS coronavirus in 2002, the MERS coronavirus in 2013, and now SARS coronavirus 2 that causes the disease COVID-19. These novel coronaviruses have caused more severe disease than what we see in the coronaviruses that circulate every year. So SARS coronavirus 2, the virus that causes the disease COVID-19, was first identified in December of 19, although we now believe it was probably circulating in China as early as even October or November of last year. Since it first emerged, it has spread globally extremely rapidly. So as of last weekend when I made the slides, there had been more than 1 million cases reported worldwide and about 57,000 deaths related to COVID-19. In the United States, we're also seeing a massive increase in the number of cases. So as of April the 3rd, there were more than 227,000 cases in the United States and about 6,600 deaths. And of course, these numbers are increasing on a daily basis. All states currently have at least one case of COVID-19, and more than 30 states are reporting that they have sustained community transmission. So the symptoms for COVID-19, symptoms tend to start between 2 and 14 days after someone has been exposed to an infected individual, and the symptoms range from mild to very severe. But the three primary symptoms that we see with COVID-19 are fever, cough, and shortness of breath. So I want to quickly compare the symptoms of COVID-19 to symptoms of influenza versus symptoms that we see with seasonal allergies. Because if you're trying to determine what an individual might have in terms of their disease, it's important to look at the symptoms and compare them across those three conditions. So as I said before, the three primary symptoms for COVID-19 include fever, which tends to be on the lower side, cough, and shortness of breath. With influenza, we tend to see very high fevers, temperatures that are over 102 degrees, for instance, chills, cough, sore throat, runny nose, body aches, headaches, fatigue, and sometimes vomiting and diarrhea. With seasonal allergies, we typically see sneezing, itching and watery eyes, itchy or runny nose, a sore throat, wheezing, chest tightness, and sometimes shortness of breath. Now, most infected individuals that have COVID-19, about 80% of those individuals are going to have a mild illness, but about 15% will require hospitalization, and about 5% will need intensive care in a hospital. Now, in contrast to that, only about 1% of individuals who are infected with influenza usually require hospitalization. So COVID-19 is a much more severe disease compared to influenza. Adults, and especially those that have comorbidities or those who are over the age of 65, are at higher risk of severe disease and death. People that have comorbidities tend to have a mortality rate of close to about 10%. And those over the age of 70 have a mortality rate between 8 and 15%. Now, in contrast, the mortality rate for individuals that do not have a comorbidity or people who are under the age of 65 is less than 1%. Children tend to have much more mild disease than adults in general. Fewer than 1% of infected children require hospitalization, and most of the children that do require hospitalization are infants under the age of 1. Now, we're not sure exactly yet, it's too early in the pandemic to tell exactly how much of a risk there is for pregnant women related to COVID-19. But if we look back at what happened during the SARS coronavirus 1 outbreak in 2002 and the MERS coronavirus outbreak that started in 2013, we know that those two novel coronaviruses were associated with negative health outcomes for pregnant women and also for their unborn children. So because of that, you should consider your pregnant employees to be high risk. SARS coronavirus 2 is a very contagious virus, and no one is believed to have inherent immunity to it. And because of that, experts estimate that somewhere between 30 and 40% of all individuals are likely to be infected with COVID-19 before the pandemic ends. We describe how contagious a disease is by using a term that's called the R0, or the basic reproductive rate. And the R0 for COVID-19 is believed to be between 2.2 and 3.1, meaning that for each infected individual, they're going to infect 2 to 3 other individuals. And so based on that, you can see and understand why the disease spreads so very quickly in communities. Now, although we have some evidence that infected individuals might be contagious a day or two before they have symptoms, individuals are believed to be the most contagious when they do have symptoms, and in particular, when they have fever and when they're coughing. Now, it's critical that symptomatic, contagious staff not show up for work. All businesses need to have a liberal sick leave policy that is non-punitive for this disaster so that we make sure that our sick employees are able to stay at home. Sick employees can spread disease in the workplace, even if they have very mild disease. So for instance, during the SARS coronavirus 1 outbreak in Taiwan, an epidemiological study found that a single infected laundry employee who worked a single 12-hour shift while he had mild symptoms, and he reported it as though it seemed as though he had a cold. So he didn't have a fever, he didn't feel as though he needed to be at home, and he wanted to continue to contribute to the outbreak response and help his fellow employees. But during that single 12-hour shift while he worked with those mild symptoms, he was linked to 137 secondary cases, 45 of whom were healthcare workers. So it's very important that whenever possible, we allow our employees to telework so that they don't have to be in close contact with other individuals. And this is especially important for our high-risk staff. And according to the CDC, the 3 groups that are considered to be high-risk staff at this time include the elderly, individuals who are over the age of 65, individuals that have comorbidities, and women who are pregnant. If at all possible, you should consider assigning those individuals to shifts or areas that involve less interaction with clients, with customers, or even with other staff. Now, before I talk specifically about how COVID-19 is transmitted, I want to quickly talk about how diseases are transmitted in general. Some diseases can be spread by respiratory droplets. And respiratory droplets are large, wet, and heavy, relatively speaking. And the vast majority of respiratory droplets fall within about 3 feet of the infected person. But some smaller respiratory droplets can actually go as far as 5 feet from the infected person. And that's the source of that 6-foot rule for social distancing. We're trying to keep people out of the range of respiratory droplets. Now, there are other diseases that are airborne. Those diseases can generate what we call airborne droplet nuclei, which are really tiny infectious particles that can attach themselves to dust particles and can be carried for very far distances, including in past outbreaks of airborne spread diseases where they were actually able to travel to multiple levels within a hospital. Both respiratory droplets and airborne droplet nuclei come out of the nose and mouth of infected individuals when they're sneezing, coughing, talking, and even when they're breathing. However, the vast majority of infectious particles are expelled from individuals when they're coughing or sneezing. Now, some diseases can be spread by what we call the contact transmission route. With this form of transmission, there's a contaminated object or a contaminated environment between that infected person and the susceptible person. So there's a risk to individuals who touch that contaminated surface and then touch their nose or their mouth. And this can happen whether the person is wearing gloves or even if it's just their bare hands. However, it's really important to keep in mind that not all pathogens, not all diseases can be spread by contact transmission. And this is true even if it's found that they are able to survive on surfaces. So now let's talk about how COVID-19 is transmitted. But another quick disclaimer here. So one of the challenges in responding to an emerging infectious disease like COVID-19 is that we don't know exactly how the disease is transmitted until we've collected sufficient data about that disease. So we're still learning about the SARS coronavirus 2 virus. But based on what we know so far, the virus is believed to spread primarily through respiratory droplets when an infected person coughs or sneezes. And individuals are believed to be the most contagious when they're symptomatic and when their symptoms are the most severe. In other words, when they have a fever and when they cough. Now, as I said before, we don't know exactly when individuals first become contagious, but again, the important thing is that individuals are most contagious when they have symptoms. Now, there's also evidence that there's an increased risk of virus spread during medical procedures that produce what we call an infectious aerosol. But those kinds of medical procedures are only going to take place in a hospital or healthcare setting, so you don't have to worry about those in your workplace. There's also some limited evidence that a person might be able to get COVID-19 through contact with a contaminated surface, but this is not thought to be the main way that the virus spreads. There is some evidence that suggests that the SARS coronavirus 2 can remain viable for hours or days on surfaces made of a variety of materials. But the infection transmission risk that's related to this is unclear at this time. COVID-19 testing has been available since late 2019. However, the first tests that were used were actually based on the SARS coronavirus 1 virus, and they weren't very accurate. Between 30 and 50% of the time, those early tests were known to cause a false negative, meaning that the individual had the disease, but the test was negative. There were actually situations where they would have a hospitalized patient in China, and they would test them multiple times, and they would have a negative test, negative test, negative test, and then finally they would test positive. So we knew that the test was not particularly accurate. Early on during the pandemic, there was also a lack of access to the COVID-19 test kits, and the CDC had strict restrictions on who could be tested. So for instance, early on, someone had to have a known exposure or have traveled to an affected area in order to be tested. So this resulted in a lot of people who probably had the disease not being able to be tested. So much of our early data was inaccurate about how widespread COVID-19 actually was due to the fact that we had those poor tests that we were using, and there was just a general lack of access to the test overall. Now, there is currently more availability of test kits and fewer restrictions on who can be tested, and we also have much more accurate tests that are now available. But access to the test kits and rules about who can be tested may still depend on your region. So you need to work with your local public health officials to find out what's happening in your region in terms of testing. Now, you may have heard some conflicting information in the news regarding whether infected individuals develop immunity after being infected or whether infected individuals can be reinfected later. Now, it's really too early in the pandemic to know for sure, but based on what we know about the MERS coronavirus, people who are infected with COVID-19 are likely to be immune after they've recovered. In fact, CDC guidelines indicate that healthcare workers who recover from COVID-19 should be prioritized to give care to infected COVID-19 patients because they do believe that the healthcare workers are immune after they've recovered from the disease. You may also have heard about a study that found that there have been some individuals who were symptomatic and tested positive, recovered from their illness, and then tested negative, but then later were found to test positive again. It's been speculated that perhaps these individuals were becoming reinfected. However, there's newer information that indicates that the negative lab test after that period of recovery was probably a false negative test. And people who test positive after seeming to have recovered from that disease are probably just continuing to shed the virus rather than being reinfected. And that is a very, very tiny percentage of individuals overall. So no one knows for sure what's going to happen during the COVID-19 pandemic in terms of when the cases are going to end and when the pandemic is going to go away, because we've never had a pandemic with a novel coronavirus. However, we've had multiple influenza pandemics throughout human history, and during those pandemics, we have found that we tend to see multiple waves of infected individuals, and each pandemic wave tends to last between 6 and 8 weeks. Now, on the slide, you can see there are 2 waves of cases that occurred, and they are circled in red here and here, and these occurred during the 2009 H1N1 pandemic, and each of those waves lasted about 8 weeks. Now, early data from COVID-19 indicates that the patient wave might be a little bit longer than this, perhaps closer to 8 to 10 weeks. However, we don't know if we're going to see multiple waves or when a second wave might occur in the United States. What we do know is that the patient surges or waves can be reduced by implementing social distancing measures, and this can help hospitals and healthcare systems deal with the patient surges that do occur. If we loosen social distancing, the patient waves will be higher and they're going to last longer, and we will have a higher mortality rate because hospitals cannot provide treatment to everybody who needs it when we have these massive patient surges. Since the onset of the COVID-19 outbreak, infection prevention measures have played a major role in controlling the pandemic and helping to minimize the spread of disease. Perhaps the most critical infection prevention measure to control the pandemic so far has been to quickly identify individuals who are infected and to place those individuals into isolation. Research shows that rapid isolation is the most important intervention to control outbreaks when a disease is really contagious, when it has an R0 between 1 and 5. And as I mentioned earlier, the R0 for COVID-19 is somewhere between 2 and 3. Personal protective equipment is also critical, especially in healthcare. And then social distancing is vital to reduce spread in the community. And lastly, hand hygiene is critical to stopping disease spread. And we're going to talk about these interventions. The CDC divides the occupational risk of COVID-19 into 4 categories, from very high-risk businesses to lower-risk businesses. Hospitals and healthcare facilities pose the highest occupational risk of exposure for their employees, primarily because healthcare staff have prolonged close contact with infected individuals and because they perform aerosolizing procedures and other medical procedures that put those healthcare staff at risk of exposure. Non-healthcare businesses have a medium to low risk of occupational exposure to COVID-19, depending on the type of business and the type of interactions that occur between employees and members of the general public, or even between your coworkers. In general, non-healthcare businesses do not involve prolonged close contact between individuals that's required for COVID-19 to spread. So as I just mentioned, in general, non-healthcare businesses do not involve prolonged close contact between individuals. This is based on the definition of close contact in relation to how COVID-19 is spread. Close contact for COVID-19 is defined as the following: being within approximately 6 feet of an infected individual for a prolonged period of time. Now, I know that there's no hard and fast definition about what is meant by a prolonged period of time, and I get this question all the time. But it means an extended period of time, such as providing care to somebody, or living with somebody, or visiting someone for an extended period of time, or sharing a healthcare waiting area or room with an infected individual for an extended period of time. Close contact can also mean having direct contact with the infectious secretions from an infected person, such as if you were coughed on, even if it was a very short encounter. So based on the definition of a close contact for COVID-19, this means that the vast majority of non-healthcare businesses are going to be low risk for the spread of COVID-19. So there are some physical barriers and equipment that you can put in place to help reduce the spread of COVID-19 within your business. And I understand there are many different businesses that are participating in this webinar, so it's a little hard to generalize about some of these. So I'm going to talk about some different examples. So one example is to consider installing some kind of physical barrier between your employee and your customer or your client. And this is especially important for individuals that have to interact with clients or customers within a 3 to 6 foot range. So for example, a lot of grocery stores are currently putting up plexiglass or other kinds of physical barriers between the person who is ringing out the customer and the customer. Now, these help to block some of those respiratory droplets if the infected individual was a customer. But it's important to know that you do not need an air purifier or a HEPA filter that's needed for your place of business. We don't even currently use those in hospitals when we are isolating infected individuals. So let's talk about how to screen your employees for COVID-19. Now, please remember, I'm only talking about screening non-healthcare staff. The CDC recommendations about how to screen a healthcare personnel are much more involved than what I'm going to be talking about today. At this time, the CDC does not recommend formal screening of all staff, meaning you don't need to screen your employees for symptoms at the start of every shift. Instead, they recommend using an exposure risk assessment. meaning that you screen your staff based on whether they had a known or suspected exposure. The CDC also indicates it's unnecessary to check employees' temperatures when they arrive on site at the start of their shift. One exception to on-site temperature screening would be in your occupational health office or department if your business has one. If they have a sick employee that shows up, they should check their temperature. But your business could choose to implement temperature screening. The CDC isn't saying that you can't, they just don't currently recommend that. But if your business does choose to implement temperature screening, you should use a temperature of 100.0 degrees as the criteria for screening. So anyone that has a temperature of 100.0 degrees or higher should be excluded from your business. Regardless of whether or not you choose to implement temperature screening, you should encourage all of your staff to report exposures or symptoms of illness. So what do you do if a member of your staff has a known or suspected exposure to somebody with COVID-19? The current recommendation is to have that person self-monitor for 14 days. And self-monitoring consists of having them check their temperature twice a day, once in the morning and once in the evening, and then report any symptoms that they have. They do not need to be restricted from duty after an exposure. If staff develop a temperature over 100.0 degrees or any respiratory symptoms while they are self-monitoring, you should just assume that that individual is infected, restrict them from duty, and switch them to home isolation. If you have a staff member who either develops symptoms of COVID-19 while they're at work, or if they develop symptoms at home between shifts, again, you should assume that that individual is infected. Do not wait to get lab confirmation of disease because that can take hours to days depending on which test is used and the lab search capacity for your local area. Symptomatic staff must be restricted from duty and they should be switched to home isolation and referred to a local medical provider. Staff who are known or suspected of being infected should be restricted from work until they have been free of symptoms for 24 hours. And this means they have to be without a fever, and without a fever also without the use of fever-reducing medication. So if the only way they can be fever-free is to take Tylenol, Motrin, or some other kind of fever-reducing medication, that does not count as being fever-free. And they also have to not have any respiratory symptoms for 24 hours. And then they could be allowed back to work. The issue of which PPE or personal protective equipment should be available or mandatory for your staff is somewhat vague. So as of yesterday, the CDC does not provide any clear guidance on which PPE, if any, non-healthcare staff should wear. The CDC instead refers businesses to the OSHA guidelines on how to respond to COVID-19. But if you look at the OSHA guidelines, it only provides a couple of sentences about information about PPE suggestions. And in essence, the OSHA recommendations or guidance says that the selection of personal protective equipment for non-healthcare staff depends on the individual's job duties. And they don't specify anything beyond that. Now, because there's a really clear lack of guidance in this area, I'm going to talk about the basic principles of infection prevention and approaches that are being discussed by individuals that work in infection prevention across the United States in relation to these issues. Masks should be worn by individuals whose job requires them to be within 3 to 6 feet of clients or customers, especially if that interaction is going to take place over a prolonged period of time. And again, there isn't a hard and fast definition of what is meant by a prolonged period of time. So you have to use your best judgment here. But it does not mean an interaction that lasts just a few minutes. In addition, the CDC now recommends that the general public wear a homemade mask when they're out of their homes. And this is actually going to help protect your employees from exposure, because if the general public is wearing a homemade mask, that's going to reduce the number of respiratory droplets that they are releasing into the environment. Gloves should be worn by individuals who are likely to come into contact with the blood or body fluids of others. So this would include individuals who are doing things like cleaning restrooms, picking up waste, or disinfecting the environment. There are no current recommendations indicating that gloves need to be worn by other people in the general public or even just worn, generally speaking, by individuals who are working in non-healthcare businesses. An isolation gown should be worn by individuals who are likely to be splashed or sprayed with the blood or body fluids of others. And this is highly unlikely to occur in any setting except for healthcare. Now, it's important to remember disease transmission can occur when PPE is not available to individuals, if the wrong PPE is available, or if the PPE isn't used correctly. So just like on this Gary Larson Far Side cartoon on the slide, where the one guy says, "Wait a minute, McAllister, you fool, this isn't what I said to bring," because he brought the on instead of the off, he brought the wrong PPE. It is important that staff have access to the correct PPE to protect them. But almost more important than this is that the individual needs to wear and use that PPE correctly, because incorrect use of PPE can lead to what we call cross-contamination or auto-inoculation, meaning that an individual can accidentally infect themselves. So, for instance, when wearing a mask, it's really important that the mask covers both the nose and the mouth. Now, I've seen individuals in the grocery store wearing a mask, but I see a lot of people wearing it where it's sitting below their nose. Now, this is not going to be completely protective, because respiratory droplets could enter that uncovered part of their nose. It's also important to know that the front of the mask is considered to be the most contaminated part, because if you are exposed to somebody who has COVID-19, their respiratory droplets are going to hit the front of that mask. So that's going to be the most contaminated part of the mask while you're wearing it. So it's really important that when you remove a mask after wearing it, that you use the straps or the ear loops rather than grabbing that mask from the front or the side of the face. The incorrect removal of masks and respirators was believed to be one reason why so many healthcare workers became infected with SARS-CoV-1 during the outbreak in 2002. Lastly, it's critically important that you perform hand hygiene by washing your hands or using hand sanitizer after you remove your mask, because your hands are likely contaminated and you don't want to touch your nose or your mouth with contaminated hands. Now, the issue of masks for the general public is sort of interesting because the recommendations have changed since the start of the pandemic until now. So originally, the CDC said that they did not want members of the general public to be wearing masks unless that individual was sick. And there were a couple of reasons for this. One reason is that the general public is not trained on how to wear a mask correctly. So wearing a mask can actually give individuals a false sense of security. And it can also lead to auto-inoculation or cross-contamination, like I mentioned before. But more importantly than that, we really wanted to conserve our masks and our respirators for healthcare personnel who are really the most highest risk individuals. Now, however, the CDC has changed their recommendation, and now they're saying they would like the general public to wear homemade masks when they are out and about in the community, because this will help reduce the spread of community-spread disease. And I should point out, this was actually the norm during the 1918 Spanish flu pandemic, where almost all individuals wore a mask when they were outside of their home. So this is not a new recommendation. It's just a change in recommendation during this particular pandemic. So as I mentioned earlier, the incorrect use of PPE can lead to cross-contamination and auto-inoculation, meaning individuals can accidentally infect themselves. And this is especially true when individuals are wearing gloves. Gloves are intended to be a barrier to help reduce the amount of bioburden or contamination that will get onto your hands. They are not meant to prevent 100% of pathogens from getting onto your hands. In fact, according to the FDA, up to 2.5% of gloves can leak, and those gloves are still considered to be fine. There was one past study that was conducted where up to 8% of unused gloves pulled straight from a box were actually found to leak. And if a water drop can get through a glove, like a picture on the slide, millions or billions of viral particles could get through, because viruses are much, much smaller than a water drop. But gloves have to be used correctly. It's really important not to touch your nose or your mouth when you're wearing gloves, because this can spread disease just as easily as if you did it with bare hands. In addition, gloves should not be worn for extended periods of time, such as from the start to the end of a shift. And they shouldn't be worn from one area to another, such as from an office setting to the kitchen area or cafeteria, and then back to the office area. And of course, they would need to be changed and hand hygiene performed if gloves were worn to the bathroom. Now, I've seen In the general public, more people are starting to wear gloves now, but I see a lot of people doing it incorrectly. They have the same pair of gloves on for long periods of time. They're not removing those gloves, they're not performing hand hygiene, and they have this false sense of security from wearing those gloves, and it's really going to put them at risk of infection. Hand hygiene is critical to perform immediately after you remove your gloves. So many business owners have asked me what measures their staff should use when handling cash or documents. Now, neither the CDC nor OSHA has any recommendations about this, but based on basic infection prevention principles, there is a low but still theoretical risk related to handling cash or documents because those items could theoretically potentially be contaminated with respiratory secretions from infected individuals. And the virus can survive for a short period of time on some surfaces. So in other words, there is this tiny theoretical risk of contact transmission from handling these kinds of items. However, it's really important to know we have not had any known documented cases of disease transmission occurring this way. And as I said before, the primary route of disease transmission for COVID-19 is respiratory droplets. It's not contact transmission. But to reduce this really small but still theoretical risk, you could offer gloves to your employees if you have them. This would reduce the risk of hand contamination. However, gloves are not considered to be necessary. Even if a staff person's hands were contaminated, they're not going to be at risk of exposure unless they touch their nose or their mouth with those contaminated hands. And they can do that even if they're wearing gloves if the gloves are contaminated. So it's really much more critical that staff be told not to touch their nose or mouth before performing hand hygiene after they've touched anything in the environment. Cash, documents, desktops, doorknobs, anything in the environment. So as I've mentioned before, hand hygiene is probably the single most important intervention that we can implement right now to try to stop the spread of COVID-19 in communities. Hand hygiene has been proven to work when people do it and when they do it correctly. But this is one of those boring messages that people hear all the time. Wash your hands, use hand sanitizer. But it really is critical. Multiple studies, hundreds of studies have found that people in the general public and also sometimes healthcare workers only perform hand hygiene correctly about half of the time. So if everyone just performed hand hygiene correctly all the times that they needed to, we could greatly reduce the risk of disease spread. So another frequently asked question I get is how a business should respond if an infected person came to their business. The most important thing to remember is that public health officials are conducting contact tracing after we identify that somebody is infected, meaning they're tracing everywhere that person has been since they became contagious. If your business is found to be a place where an infected person has visited or been, public health officials will then give you instructions on which of your employees need to be self-monitored or sent home to self-quarantine. There is currently no evidence that suggests that a room or building needs to be shut down after an infected person has been in that area. The area where the infected person has been requires only routine cleaning using an EPA-registered product. If you go to the EPA website and you just search for COVID-19, a list of approved products will come up. When cleaning the area where an infected person has been, cleaning should be focused on areas that are touched most frequently, like doorknobs, tables, keyboards, etc. If you work in occupational health, if you work in emergency management, or you're a business continuity specialist, or if your company employs such individuals, you or they might be interested in receiving formal education about how to prepare for naturally occurring or man-made infectious disease disasters, including things like bioterrorism, outbreaks of emerging infectious diseases like the Ebola crisis from 2014 or COVID-19, and other pandemics. St. Louis University offers online education in biosecurity and disaster preparedness, including both a graduate certificate that consists of 15 credit hours or a full Master's of Public Health degree. If you're interested in this, you can find out more at slu.edu and simply search for biosecurity. So what I hope you learned today during this morning's webinar, COVID-19 is primarily spread by respiratory droplets. It's really important that we rapidly identify that somebody is infected and place those individuals into isolation right away, because that, with hand hygiene, will be the single most important intervention that we can put in place to stop this pandemic. You need to restrict your symptomatic staff until 24 hours after they have resolved all of their symptoms, including being fever-free, without having fever-reducing medications, and without having any respiratory symptoms. PPE is important, but it's more important that it be used properly. And then lastly, hand hygiene is probably the single most important intervention that we can put in place in most non-healthcare businesses to reduce the spread of disease. So that concludes the webinar. Jennifer, we're now ready for questions.
Great, thank you so much. It is time for Q&A. So if you have a question for Dr. Rebmann, simply type it in the chat box in the lower left corner of your screen and be sure to click the send button. Moderating Q&A is Chris Ruiz with APIC. Chris, I'll turn it over to you.
Thank you, Jennifer. We have a couple questions, one from Tamara. There's the CDC guidelines state 72 hours free from fever symptoms. During the presentation, Terri, you did mention that it was 24 hours. Would you like to address this question?
Yes, when I checked it, the guidance that I looked at, and there is some conflicting guidance on the CDC website, I saw 24 hours, so I would need to double check that to see where it says 72.
Okay. And another question from Susan says, how many days back should contact tracing go for confirmed cases?
So public health officials, I believe, are currently looking at 1 to 2 days before symptom onset when they are doing contact tracing. But I also know from talking to local public health officials that everyone seems to be handling it a little bit differently because there aren't clear guidelines on exactly when they should start, how far back they should go in terms of contact tracing, because the data on exactly when individuals become contagious is changing very rapidly.
Okay, thank you. And I actually have a question. Do infected surface times vary depending on the type of surface? For example, like metals or cardboard?
They do, yes. The virus has been found to be able to survive for different lengths of time depending on what that surface is. But again, the more important issue is that we don't know what infection risk it actually poses simply because it exists on a surface. So just because it's on cardboard or just because it could be cultured off of cloth or a desk or what have you, we don't know that that actually translates into infection transmission to other individuals.
Okay. Okay. Does anybody else have any questions? Those are the only few that I'm seeing now. We got one more question. Is a lag of infection risk exists for more rural areas compared to urbanized areas?
I'm sorry, was that question, is there less transmission risk in rural areas?
I think there's a bit of an assumption. I guess they're saying, is there a lag of infection risk that exists more for rural areas compared to urbanized areas?
I'm not exactly sure what's being asked, but I can describe from an epidemiological standpoint, what we're seeing so far is that we are seeing more disease transmission in urban areas, which makes sense because in urban areas, people live closer together and there are more individuals living close together compared to in rural areas. And so we see more disease spread in the urban areas than we tend to see in rural areas. But that doesn't mean that we couldn't have outbreaks or disease spread in rural areas.
Right. Okay. Thank you. And another question from Corey, is there a chart or list of the best cleaners or lengths of time to disinfect different surfaces?
Yes, on the EPA website, there's, if you type in COVID-19, a list of all of the EPA approved cleaners will come up that are specific to COVID-19. And each cleaner has its own recommendations about dwell time in terms of how long after you spray it on it needs to sit before you wipe it off.
Okay, thank you. And Thornton asks, what safety precautions are most critical in a drive-through scenario? For example, gloves, cleaning canisters between customers, etc.
Having a mask on would be the most important piece of PPE for individuals that are working in a drive-through setting. Gloves, as I mentioned before, are going to reduce the risk of contamination getting onto the worker's hands. But as long as the individual is performing hand hygiene before they touch their nose or their mouth, there's not going to be a risk to that person regardless of whether or not they're wearing gloves. I have seen in some fast food restaurants other interventions that are being put in place with putting the straw in a bag before handing it to the customer. There's no evidence of other kinds of interventions like those that need to be put into place. Again, you have to remember the disease is primarily spread by respiratory droplets, so that risk of contact transmission is very, very low. We don't have any known cases of individuals getting infected from contact with contaminated surfaces. So those extra precautions that some businesses have put into place, there's not really any good scientific evidence that you need to be doing those kinds of interventions.
Okay, thank you. And another question from Susan, could you comment on manufacturing companies shutting down for days in cleaning? Any recommendations, or would you recommend that?
Manufacturing plants that were shutting down to clean because they had an infected worker there? Is that the assumption?
I'm assuming, yes, that they would be shutting down just so they could disinfect.
So, again, there's just a theoretical risk of contact transmission. So, there are currently no recommendations that say that an area or a building need to be shut down with extra cleaning or decontamination or disinfection that needs to take place. Routine cleaning only is all that is currently recommended after an infected individual has been at a place of business. So there aren't any current recommendations that would indicate that you would need to shut down a building to do extra cleaning.
Okay. And another question from John, any PPE recommendations for personnel conducting temperature screening at non-healthcare settings?
If you're conducting temperature screening, it would be important to have a mask on. It would probably be best to have an isolation gown and gloves on as well, because when you're doing temperature screening, you are going to be in very close contact with that individual within just about a foot of them. And so it would be important. I would have that individual wear an isolation gown, gloves, and a mask.
Okay, thank you. And another question from Leslie, is there an estimate from CDC on when they expect businesses will resume to normal?
I've heard a lot of discussion about this. I actually haven't heard anything from CDC, but I've been in discussions with a lot of different local public health officials and some governors who help make those decisions about when that's going to happen, and nothing definitive has been decided. They're trying to look at what indicators would tell us that it's safe to reopen businesses and how we might do that in terms of whether we would loosen the restrictions a little bit and see what happens with the number of cases in a community, or whether we would loosen it more and again see what happens. So, and I don't know if it's going to happen with universal recommendations across the United States, or if regions will make different choices about how they're going to loosen those restrictions or when. But I do know that probably a lot of the decisions will depend on what's happening in that community in terms of disease spread and the number of cases that they have. Because we do know that the more restricted precautions that we have in place, the lower the number of cases that we have in an area, and that has a huge impact on healthcare surge capacity. And when we start exceeding that healthcare surge capacity, that's when we start seeing an increase in the number of people that die.
Okay, thank you. And a question from Joanne, what would be the best way to launder homemade masks?
I have not seen any recommendations on no standard recommendations on how to launder homemade masks. So I assume if you laundered it the way you typically would any other piece of laundry, that should be sufficient. There's currently the only science that exists on homemade masks this time relates to the type of cloth or material that's used and how many layers are used, and it's very early science. No recommendations have been made regarding what would be the best kind of homemade mask, and I haven't seen or heard anything about how those homemade masks should be laundered. So since that's my sort of disclaimer, since we don't have any recommendations, I would say for my family, what we are doing is we are putting them in the laundry.
Okay, thank you. Are there any more questions related to any content-related questions? All right, I don't see any more. Thank you so much for answering all of that. One more. Do you know the status on any vaccine trials?
Yes, a little bit. So the thing to keep in mind about vaccines for COVID-19, we don't currently have a vaccine against any human coronavirus, and we've been attempting to make a vaccine against the novel coronaviruses, SARS-CoV-1 and MERS-CoV, for more than 10 years, and we don't currently have a vaccine. We do have multiple vaccines that are in phase 1 clinical trials now for COVID-19, but the process to get a vaccine through all the different phases and be approved by the FDA for release takes between 12 and 18 months. So the soonest that we would have an approved vaccine that's released for use, the most optimistic estimate would be a year from now.
Okay, thank you. All right, and that looks like that's it for the content-related questions. Thank you so much again. Jennifer, would you like to take it from here?
Great. Thank you very much. A special thank you to our presenter and everyone who participated in the program. If you missed any portion of the webinar or would like to simply view it again, you may access the archive from an email we will be sending out to you later on. It will be sent to each participant. Today's program is copyright 2020 by the Association for Professionals in Infection Control and Epidemiology with all rights reserved. This does conclude the program. Have a wonderful day, and you may now disconnect.